Okay. So I was able to start the recording. So today's Grand Rounds question and answer has 7 clinical students who will be giving a brief overview of their case. And then we will have a few questions from faculty, and then any questions from the audience will be welcomed, and then we'll move on to the next. And I do want to welcome any of our accepted students that are here sort of observing. Welcome to this experience. And I think we have a good amount of half years this year, I see, and first years, so this should be great. All right, so we're going to start this session, got it recording, with, and I'm going to jump around. So we'll just start with Matt Briscoe. So Matt, if you can unmute and give us a quick synopsis for those who may not have seen the presentation, and then we'll go to questions.
All right, so for my case, it was a 37-year-old female who kind of presented to the ED with renal colic. It had been going on for 12 hours, and she had a previous episode 1 month prior. So then basically we started the workup, did an ultrasound, found another stone, and noted hydroureter and hydronephrosis on the ultrasound. Urology was consulted, and she was ultimately taken up to the OR directly from the ED for stent placement.
Great. Professor Kearney, did you want to ask your question?
Hi, Matt. Good case. I'm wondering if you can explain what made this a non-obstructing stone versus an obstructing stone.
So that read kind of came from urology, and then also for the stone to be obstructing and causing hydroureter, you wouldn't expect the renal stone to cause that because it's like above the level of the ureter. So you would expect urine to still be able to get past that. So you would expect dilation from like proximal or like superior to the stone location, not really from where the stone was. So it was kind of a discussion we had whether the hydroureter was just a remnant from the last stone that was seen a month ago, or if she had another one lower down in the urinary tract that just wasn't seen on ultrasound.
Okay.
Great. And Professor Connors, I believe you had the next question.
Yeah, so Matt, in your presentation, you said that she was lost to follow-up. Do you know why that occurred or some of the things that could have prevented that?
So I think you mean like the first time, after the first time she was seen?
Right, that she didn't do the follow-up with urology because what was the reason? Because access and how could that have been avoided?
Yeah, so what she told us, we never really spoke with the urology, whoever she was supposed to be seen by. She said that they were like requiring COVID testing to be done before she could be seen in office. And she said she had gotten the COVID testing done and had a negative result, but still wasn't allowed into the office for some reason. So some things that could have been like done to kind of prevent this, she could have tried to find another urologist, or she could have gotten in touch with her primary to see if they could refer her to someone, or it could have just been done over a telehealth visit at that point. Since she was kind of asymptomatic, I don't think an in-person exam probably would have noted a lot from that.
Okay, so that was complicated by COVID because follow-up sometimes can just have insurance barriers or they didn't have a primary care. So that was even extraordinary follow-up. Thanks.
Great. Any questions from the audience for Matt? All right, really great job. Thank you, Matt. All right, and so next will be Lucia. You can unmute and give us a synopsis.
Okay, so my name is Lucia Ferrarc, and I just finished my rotation at Mercy Medical Center for inpatient. So for my grand rounds case, I did a 78-year-old female. She presented with increased shortness of breath and lower extremity swelling for the past 2 weeks. We planned to admit her for treatment of acute CHF exacerbation. However, we found her to be acidotic on an ABG. So we planned to start her on BiPAP. However, she kept ripping off the mask and she couldn't tolerate it. So we put her on high flow O2 and said, if you start to become obtunded or your mental status declines, or we might have to intubate you and send you to the ICU, which she understood. And that did happen. Her mental status started to decline. She was retaining CO2. So we ended up transferring her to the ICU. She ended up having to be intubated. Unfortunately, she didn't have an advance directive on file, and her family was consulted, and they made her DNR DNI. Didn't think she would want to live like this. So she ended up being extubated and passing away about 3 days later. But overall, it was a really interesting case.
That sounds really complicated. Professor Nibala, you have the first question.
Hi, Lucia.
Hi.
Okay, so I have a few questions for you. One, on physical exam, you noted that there was a lower extremity edema. Where did that extend to?
It extended just up to about her knees.
Okay, so pretty
So it was
extensive.
Yeah.
So foot all the way up to the knee, 2+ pitting edema. So a lot.
Yes.
Okay. Do
Yes.
you know, did you have records of her baseline ejection fraction, or did the ER do a bedside ultrasound to see how her ejection fraction was when she was in the emergency room?
So in the ED, they didn't do a bedside ultrasound or echo. However, she was followed closely by cardiology, and her ejection fraction was observed. It wasn't reduced. So we were kind of going off of that. I don't
So
think
prior
we
to
didn't-
presentation, she had preserved ejection fraction, but at presentation, we don't know what happened.
Correct.
Okay. And then you talked about how she wasn't on anticoagulation for her AFib.
Yes.
What is her CHADS VASC score? And what is the primary role of anticoagulation for AFib? What is like the primary thing we're preventing?
So when patients are in atrial fibrillation, their heart, so in the atria, they're kind of moving at an unregulated pace, and there's a little outpouching of the left atrium called the left atrial appendage. And so when the blood is really turbulent in there, some blood can get stuck there and clots can form. And atrial fibrillation is one of the main causes of, DVTs, pulmonary emboli, strokes, because that clot will move to other parts of the body, which is why primarily we do place patients on anticoagulation. And for her CHADS VASC-2 score, that is a fabulous question. So
Is it high or is it low?
she has never had a prior stroke, but it would be much higher. She is older, and she has multiple risk factors. She has hypertension, she has AFib, she has CHF. So she does have a high score, which means her risk of having a stroke for her secondary to her AFib is highly likely.
Yeah,
which is,
so
sorry.
No,
I was gonna say
good.
that's one of the reasons why we decided to get a CT scan when her mental status started to decline really rapidly. I didn't say that in my little blurb, but unfortunately CT scan won't show an infarction right away, but we weren't able to get an emergent MRI. So we kind of went off that it wasn't a stroke or anything like that causing her decline in mental status.
Okay, good. I just wanted to focus on that point of, the primary prevention really is a stroke. Just think of proximity of things, but yes, other emboli can happen. And then what did you learn from this case? I mean, this patient ultimately died. Are you
Yes.
happy with the workup? Are you not happy with the workup?
I think the workup we did was good. I think I learned a lot about how patients can present one way and have something completely different going on. Come to find out, her husband, when we spoke to her, said that she's had periods of unresponsiveness where she'd just stop answering and kind of her mental status would just decline, and then she would just come to again, which is kind of what happened in the emergency room. She stopped talking to us, only responding to painful stimuli. And then when we took her down to the CT scan, she was conversing with everybody, full conversations. So this has been going on for a long time, and she just didn't present with it. And so, initially we were just gonna admit her, give her some IV Lasix and kind of send her on her way. But then we found her to be in this severe acidotic state, and, you know, things just kind of went down really fast.
Lucia, did you consider a CTA of her chest at any point?
So we did. So I actually asked my preceptor about this because she did have an elevated D dimer, and she presented she could have had a PE. And what I didn't know, which I actually learned on the rotation, was that D dimers can be age adjusted. So because she was 78, her adjusted D dimer range was up to 390 and her level was only 357. So technically she wasn't considered to have an elevated D dimer.
Great.
So that's why we didn't get the chest CTA.
Great.
Very good. And then there was one more question. Was she treated with any other medical interventions in the emergency room?
She was put on oxygen just for that. She had one episode of hypoxia in the ED. She was put on oxygen. I think they started her on Lasix in the emergency room, but that was ultimately an order from inpatient medicine for that, but she wasn't given anything else in the ED.
Okay. Great. Does anyone else have any questions for Lucia? All right. Great job. Thank you, Lucia. Next, we have Ashley Pacheco.
Hey everyone, so I'm Ashley. I presented a case for my general surgery rotation a couple months back. So I had a 36-year-old male who had come into the ER with about a week of periumbilical pain in his abdomen, along with some discharge from his belly button. He had gone to an urgent care as an outpatient because his symptoms were persisting, and he noticed that the discharge went from this kind of clear fluid to more like thick white and more purulent in nature. So they did start him on Augmentin, and he was on that for 3 days before he came to the ER to see us with no symptom improvement. So his exam was pretty specific, remarkable for some tenderness around the belly button, and he did have purulent drainage in that the belly button with some redness around the area. But otherwise his exam was unremarkable. He was a little tacky at 100, but he was afebrile. We were thinking about an intra-abdominal wall abscess, but we did get a CTA with CT abdomen with IV contrast, and it actually showed a small fluid collection just deep to the umbilicus. And as you actually scrolled through the thins towards the feet, there was a sinus tract that connected that abscess or the little collection of fluid to his bladder. And they decided that it was consistent with possibly a urachal remnant. So we ended up just initially treating the patient with some antibiotics, but then when we did some more research, as this is not a very common finding, we ended up bringing him into the OR for an exploratory laparoscopy, and we removed the infected cyst as well as most of the remnant, and he did very well after post-op, and we ended up sending him home on some outpatient antibiotics with follow-up.
Great. All right, Professor Kearney.
Hi, Ashley.
Hi.
In looking at your interesting case and in looking in your physical exam, you documented appropriate words, but I had a hard time really getting a picture of exactly what it looked like. So you said that it was erythematous and that there was drainage. Can
Yes.
you expand on just paint the picture for me?
Yeah.
Like, was it indurated? Did it look cellulitic? Could you express discharge? Was it fluctuant?
Yeah. So when we went to see the patient, just looking at it, just without really touching him or anything, there was just some redness, kind of consistent. It looked a little cellulitic in nature, just kind of that bright red that was kind of sharply demarcated, similar to a cellulitis type picture. Mm-hmm. And just looking at it without pushing on him, there was like a puddle of very thick white discharge in his belly button. When we pushed on it, it did release some fluid, but there really wasn't any fluctuant mass. I couldn't palpate anything on exam, and we couldn't really see any sinus or anything connecting internally. Mm-hmm. But he definitely was tender in the area. He wasn't rigid or anything like that, but he definitely had some tenderness all around his belly button. But the erythema wasn't super widespread. It pretty much remained right around the area, circumferentially around his belly button.
What was your thought process? I think it's great that you guys got the CAT scan and found this diagnosis, but I feel like that kind of exam could have, in certain settings, I feel like he could have been sent home on antibiotics, clean your belly button and take an antibiotic for a possible cellulitis or early abscess. I'm interested, did you guys have a discussion, or was it just automatic that you ordered the CAT scan?
So we actually, like, surgery didn't order the CAT scan.
Yep.
The ER actually got the CAT scan. So I don't know their rationale, but I'm guessing based on what I kind of know is he was sent home, or he went to outpatient urgent care and got sent home on Augmentin, which I'm assuming they were thinking was more of like for cellulitis.
Yep.
And he had that for 3 days before coming in, and his pain was worse and constant, and he still had all that discharge. So I think that's why they were kind of like, something else must be going on. Either we're not covering something, or there's something deeper in the tissues going on.
Yep.
So I think that must have been their rationale, but I can't fully speak for the ER, but that's at least what I took from that.
Yeah, and I think combining the exam might have looked somewhat benign, but the amount of pain he was having, that pain disproportionate to the exam, makes me think about necrotizing fasciitis, which might prompt me to order the CAT scan just to look for gas in those tissues. But
Yeah.
really great. Good job.
Thank you.
Professor Nabala?
Hi. Interesting case, as Professor Carney said. Based on your evidence-based medicine, are you happy that you did the XLAP, and did you get path back?
Okay, so I'm very happy we did the XLAP. Just because it's kind of interesting too. My patient actually presented more like a child did in my study, which I thought was kind of interesting, but he was younger. He's only 36. But hearing about the risk of like urethral cancer and the severe like morbidity and mortality, I believe it was like a 45% 5-year survival rate. I was very happy that we ended up doing the surgery. I actually kind of talked to my attending about this, the surgeon, because originally we were going to treat him conservatively and kind of see how he did. But I think the surgeon had only ever performed this one other time when he was like a resident. So it's kind of like this very rare thing that most of us didn't know much about. So I think he kind of did more research and kind of saw the cancer risk and was like, we just need to get this out. In terms of the path, I kept trying to find it, but unfortunately, when he got discharged right the day after the surgery. And I was kind of limited to what I could see because he wasn't the patient anymore. So I'm not sure exactly what the path came back as. I looked into like what the pathology could say. So they basically would look for like fibrous cords and like tubules like within the pathology samples that we sent, and look for like urinary tract like epithelium like that connects to like, we didn't go all the way to the bladder, just for risk of damaging the bladder, because obviously we're general surgery, not urologist. But that's at least what they would be looking for. But unfortunately, I didn't see a final pathology report.
I think it's great though, because, sometimes we forget after being out of school that you're still learning, and here the surgeon still looked something up. So you're a perpetual student. And I think this case just really emphasizes how important it is to look things up and say, that's not normal. What is this? I'm going to look into a bit further. So I thought that was great.
Yeah, it was definitely a humbling experience because they said urachal cyst and I had no idea what was going on because I saw the patient in the ER before I looked at any of the like CT images or anything like that. And then I read the impression and I was like, I'm going to have to look into this. Like, I'm not sure what this is. So definitely a good experience overall.
That's great. Professor Miles, I think you had a question.
Yes. Hi, Ashley. How are you?
Hi, good. How are you?
Good. Just my quick question, and I know the focus on this case was the surgery, but when describing the vitals, they were stable and the blood pressure was 166/109, and he had no medical history, not on any medication. So was this blood pressure just more related to his pain level?
Yeah,
and,
I think.
And what was that repeat at the end? Because at discharge, that would have been something he had to address going home if this was an ongoing problem.
Yeah, so that definitely was something that I like first when he got admitted kind of noticed right away, and he had no, like you said, no pertinent history of hypertension. He was extremely anxious about the entire situation and he was in a good amount of pain. So I think it was kind of a combination of his anxiety because no one hears about fluid coming out of your belly button. Like that's kind of a very odd thing to be going through. And I think because he'd been having this for about a week at the point that we saw him, he was just very nervous about what was going on and was kind of confused about what was happening. And I think his pain also contributed, but he was normotensive when he left. I believe he was like 130 systolically, so much improved, but he still had some pain when he left, but it was a lot better. So we didn't think that he needed to follow up like as an outpatient to check anything for his blood pressure.
Yeah, well, I mean, it's significantly high. I mean, that's for sure.
Yeah, definitely.
Do you
especially
think
for
that,
someone without history.
Do you think that the mesh at age 12 had anything to do with this abscess?
So I don't think
Unrelated.
so. I think this is probably something that he's had for a long time and just never even knew about it. And then we kind of always learned, like, I remember talking to Jim Severance. He always used to teach us in lectures. And when I was on rotation, like, if sterile fluid isn't moving, it's supposed to move and get out. Like, we're supposed to excrete urine for a reason. If it stays in the same place, like, it's going to cause an infection. So I think, unfortunately, over time, it just, I don't know if he had like some reflux of the urine back up through this tract or what happened, but I think it was bound to happen eventually. And it just unfortunately happened at this point, but it was good at least that we found it, because we even asked him if he had ever been told that he had a remnant, and he had no idea what we were even talking about. So it was definitely an interesting situation.
Yeah, no, it was a great case. Good job.
Thank you.
All right, any other questions? All right, thanks, Ashley. Next, we have Samantha.
Hi everyone, my name is Sam. My grand rounds case is on 11-month-old with 2 days of fever, fussiness, and difficulty sleeping. His mom was concerned that he had an ear infection because he would cry when she touched his ears, but his physical examination of his right ear was normal, and then bilateral tympanogram testing was normal. But otherwise, his vitals were within normal limits, and he didn't clinically look sick. And he didn't have any other signs of infection, such as an erythematous throat, a runny nose, a cough, abnormal lung sounds, GI disturbances, no foul-smelling urine, and he had no sick contacts. So we decided that close observation along with supportive care was the best management. We informed his mom that it was likely a bacterial virus, and that if he broke out in a red rash on his in a few days, it was probably roseola, which is also a relatively common viral infection that would clear on its own with supportive care. And then 3 days later, via telehealth, we saw them again.
Samantha, why don't you pause? Leah Mills, can you mute yourself? And Dr. Rosenstein, can you mute yourself?
Sorry about that.
That's okay, thank you. All right, go ahead, Samantha.
Okay, so 3 days later, we saw them again on telehealth, and his mom reported that his fever was now gone, but he had a red rash on his trunk. So we educated her again on what roseola was and had them continue with supportive care, so Tylenol and Benadryl. And that was it.
Nice job, thanks, Sam. All right, Professor Baginski, you had a couple questions.
Sorry about that. Okay, yes, Sam, in your presentation, you were talking about, and part of your differential was concern for possible sepsis. You did mention that he was older than 3 months old. And can you explain to us why that makes a difference?
Yeah, so with kids that are less than 3 months old, the physical exam is much less reliable, and the chance for an occult bacteremia is much higher, so it's taken much more seriously.
And are there any additional testing or anything specific that would have had to be done if you were with a child with a fever who was less than 3 months old?
Yeah, if they were less than 3 months old, we would have highly considered having them go to the emergency department for like a full sepsis workup. We would have definitely at least gotten some blood at the visit, but they would have needed more testing. Absolutely.
There's one specific test that I was kind of aiming for.
So I mean, blood testing being like looking for a white blood cell count, getting cultures of that, urinalysis, urine culture, and they also normally do an LP.
Yes. Also, in the office, you mentioned that he had moderate amount of cerumen in the ear canal to the point that it was difficult to be able to see the tympanic membrane. How useful is a tympanogram in the case where the ear canal is blocked with cerumen?
Yeah, so cerumen can cause the tympanogram to be abnormal. there was enough cerumen that I was blocking it, and this baby was kind of thrashing around and was really irritated. So we didn't want to go in and try to take out the cerumen again and then look again with the otoscope. So instead of that, the tympanogram offered more of like a painless and easier way of assessing, since it wasn't completely blocked. It was enough that we felt that it wouldn't completely make the tympanogram abnormal. And if it was abnormal, we could have also went back and tried to get the cerumen out to see if it was the cerumen or if it was actually an acute otitis media. But when we did the tympanogram and it had that point instead of being flat, that basically assured us that it wasn't an acute otitis media.
And then finally, for people who don't know what a tympanogram is, can you describe it and what it shows and how you do it?
Yes, so the tympanogram is a really helpful, painless, objective test. It has this small little probe that you put into the ear. It's soft and plastic, and it creates a seal, and it sends out like a sound, a tone that hits the tympanic membrane, and it goes back to the instrument. And depending on the compliance or how stiff the tympanic membrane is, it'll send back different tones. And the tones that are sent back create a graph. And when the tympanogram has, I don't know if you guys saw the presentation, it has basically a peak that shows that the tympanic membrane, the stiffness is normal or within a normal limit. But if it's extra stiff, the tympanogram, the graph that is produced will be flat, will be like a flat line.
Okay, thank you, Sam. And then Professor Nabala.
Okay, Sam. So I have a new baby too, and I think about this 11-month-old and the mom, and you educated that they should increase fluids. How many more ounces should my baby be taking in with a fever?
So specifically for a baby, I don't know the exact amount. However, we essentially just told her, you know, you can do an extra few bottles, or as basically as much as that they would want, like be able to do, because most likely they're going to be irritable and not wanting to feed as much already. So even if we set a certain amount, I'm not sure that they would have been able to. So we didn't give a certain, like a specific amount to say, this is how much more you should be doing. In the adult population, there is a certain like a milliliter more amount depending on the fever and how high it is. But what we really just said was to increase it as much as you can.
Great. Any other questions for Sam?
Hi, Sam. I had a question. So I was just curious. I was reading a little bit about roseola, and I was wondering what made you prescribe the Benadryl, just because from what I had seen, it's not typically given to children under 12 months. I know your patient was 11 months, but and then the rash doesn't normally present as itchy. So I was just wondering like what factors were taken into consideration with that prescription.
Yeah, so I also saw that, and I kind of looked into it. So the main concerns with Benadryl in the younger population is convulsions, tachycardia, and potentially life-threatening dysrhythmias, which is concerning. However, what we observed, like on that telehealth appointment, was that the infant was in severe discomfort despite Tylenol treatment. So although typically the rash may not have been, you know, pruritic, what we could see was that this baby was in severe discomfort, and we believed that the added benefit and added relief that the Benadryl would provide would outweigh the risk.
Great. Any other questions?
Can I jump in on that for a second? Just because I'm having a hard time leaving it alone.
Yes, please.
This is Dr. Rosenstein, who's also a pediatrician. The rash really should not be uncomfortable, painful, or itchy. So if the kid was uncomfortable and the fever was gone, I'd be concerned about looking for another cause of discomfort. Does the Benadryl make discomfort go away? Pain, let's just say pain and not itching. Does Benadryl make pain go away?
Not pain, no.
No,
And they
Benadryl makes people sleep so they don't complain about being painful. And then the other thing you have to be careful about with kids in Benadryl is, have you ever heard of a paradoxical reaction? You want to explain what that is?
Yes, so it typically causes sedation, but the paradoxical reaction that some kids can get is when it causes the absolute opposite and causes them to have, I think that's also where the dysrhythmias come into play, but like stimulation and just the opposite of sedation.
Yeah, so dysrhythmias can happen with overdoses, and overdoses are always a risk when you dose a liquid medicine by weight, and people aren't good at math. But the paradoxical reaction is about 15% of kids, instead of getting sleepy, get wild. And then you just have a whole second problem. So just something to think about, that you may just be hiding a symptom rather than treating a symptom.
Great. Thank you. Any other questions? Okay. Thanks, Samantha. Now we have up Oliver.
Hi, I'm Oliver. I was at Encompass, a rehab facility in Ludlow, and my patient was a 58-year-old female who presented with a primary diagnosis of a cerebrovascular accident of the middle cerebral artery with dysphagia, aphasia, and right upper extremity weakness and right facial weakness. So during her hospital course, she was introduced to occupational therapy, physical therapy, speech language pathology, and respiratory therapy followed along just for some of her comorbidities, such as like COPD, and she was managed for that. Basically, she developed a UTI over her hospital course, and that was treated, and she had some transient chest pain, which was investigated with an EKG, but it was reproducible on a physical exam, so it was deemed to be musculoskeletal. Then she also had a cough, which was happening for a couple of days, and that was investigated. They thought it might be COVID or something to do with aspiration, since she was having trouble swallowing, which is why she had a G-tube for feeding. She's fed with the G-tube, and the X-ray was negative, and speech language pathology didn't say anything about it, and she was COVID negative, and so that was basically the hospital course. And she did progress in OT. She was able to walk PT fairly well and ambulate with a walker supervision.
Okay. So Oliver, I had a question. So the patient had a past medical history of factor V Leiden mutation, correct?
Yeah.
And was on, chronic anticoagulation as part of her medical history, right? So
Right.
Can you talk about the incidence of embolic stroke in patients with factor V Leiden mutation on chronic anticoagulation? Is this a common thing?
No. Well, first of all, I think not even with anticoagulation, it is extremely uncommon for them to have an embolic arterial stroke on a factor V Leiden someone with that mutation. But anticoagulation, I have no idea.
Okay.
But it's uncommon for them to present that way.
Yeah.
Even like without anticoagulation.
Okay. And so I think that was one of the big questions that was sort of popping out to me throughout the whole case, is it seemed like this was a pretty rare case presentation. And I would have loved to see, your evidence-based medicine maybe based around that, as opposed to what you did your evidence-based medicine on, because it didn't feel like it really matched your presentation. Just, thinking about that going forward.
Yeah, and personally, I think it would probably have to do with their comorbidities, because, like I said, they said it was like a calcified emboli, so that probably could have came from with an arthroma. She was on a statin. She has hypertension, has diabetes.
Yeah.
So I think it was more due to those risk factors than the factor V Leiden.
Okay. All right, and then Professor Connors, you had some questions.
So Oliver, so this woman had a significant psychiatric history. She was on three different antidepressants, and then she's is clearly just had a life-changing health emergency at a young age, and she's probably isolated because of COVID in a rehab facility. So what prompted the UA? Because it seems like she had a mild change in her behavior, which could be attributed to the things that I just aforementioned. And what prompted you guys to get a UA?
Well, basically because her depression didn't seem to be like in documentation or on physical exam, and for the few days she was there, she didn't really seem to be affected by that. And she just became more like agitated with things. I didn't mention, but she had a CPAP and she was kind of refusing that at night too. And so it wasn't just like depression. I didn't see it. It's hard because she was aphasic too, so you had to do everything based on what you suspected, and it was something to consider because she had that psychiatric history, and also that there's post stroke fatigue and depression that can occur too. Could be worsening of that. But she just seemed to have a positive demeanor, and I thought, and like I guess the other people there thought that it could be an infectious process, and so they wanted to investigate that more because she was aphasic. They kind of wanted to cover all the bases.
No, it was a great call. I mean, you could have very easily just summed up her, mild, her change in affect to many of the things that you mentioned. She's isolated, she's had a stroke, she's aphasic, she can't see her family, and not done due diligence that there might have been an underlying organic cause. So,
Well, that was another thing. Her family did come to the window and like friends, but it was like too much for her. So she kind of had like a negative reaction to that. And even when talking to her partner on the phone, she had a negative reaction. So that was another thing to consider.
Great. Any other questions for Oliver? All right, thanks, Oliver. And now we'll have Emily.
Hi, everyone. So my name's Emily, and I did my presentation on a 35-year-old female who I saw at Bay State Medical Center on my inpatient rotation last month. So she presented initially to the ED. She doesn't have any really significant past medical history. She was complaining of intermittent bilateral headaches starting at the bridge of her nose, then going back to both sides of her forehead, down posterior head and neck for the past 10 days, associated with occasional nausea, photophobia, and blurry vision. These headaches were many relieved by Tylenol. They're worse with movement, yelling, talking really loud, laying on her side. And Excedrin didn't really help the headaches at all. Her physical exam was relatively unremarkable, and there was no deficit noted on the neuromusculoskeletal exam. They got a CT head and neck in the emergency room and consulted neurosurgery initially. Then they got a bunch of labs, which are all otherwise unremarkable. But the CT head showed about a 5.6 centimeter solid left temporal mass consistent with a meningioma and a 9 millimeter midline shift with hydrocephalus and surrounding edema. Neurosurgery also recommended a stat MRI, which, as we know, in hospitals are not done right away. So then that eventually also confirmed this mass. They also got a CT angio head and neck in the emergency room, which didn't show any hemorrhage. And then neurosurgery also recommended getting a CT chest, abdomen, and pelvis just to look for any metastatic lesions, and there were none. She was started on dexamethasone for cerebral edema, Keppra for seizure prophylaxis, and famotidine for GI prophylaxis. She was admitted to neurointercare for Q2-hour neurochecks, and then was taken to neurosurgery later that week, and eventually discharged on post-op day 3. The pathology report showed a meningioma with mesothelial-type cells, and it was a Hood grade 1 meningioma.
Great. It was a really good presentation, Emily. And I wondered, in the presentation, you sort of stated that the patient was discharged home. I think you said like with appropriate follow-up care. Can you just describe what that follow-up was?
Yeah, so she, at Bay State, this is what I noticed, with COVID, I was on like a cross cover team. And then I also saw this patient when I was on the day team, and the neuro patients are taken care of by neuro and are admitted to them. So they're kind of like in their own little like subsector. But then we also were seeing her for inpatient, which was kind of unique with this patient. And neurosurgery kind of really took the lead on this one. So I was trying to like dig through the records and get as much as I could from the neurosurgery notes, because we were following up with her daily on the medical side, but neurology was also following up with her daily on the neurosurgery side. So she was discharged, and I'm assuming is following up with neurosurgery in office. And I was hoping that they would maybe do like an oncology referral as well, to kind of work up the meningioma more, to get the genetic testing, which I thought should be done, to kind of work up. So I'm assuming it's appropriate follow-up, but that's why I kind of made a blanket statement versus like being more specific.
Yeah. Okay. Makes sense.
I would look to Emily, hearing that, like, where's she gonna go? You would assume that in someone's discharge paperwork, it says like, call this number that is neurosurge office and follow up in 1 to 2 weeks, right? Like, I hope that on her end, it was much clearer because she has a very significant diagnosis and should not get lost to follow up. Yeah. So I hope that someone, and sometimes when inpatient's involved, that's a really like key point to the inpatient team, is to connect those dots of the specialty services to make sure that this person knows where they're going, because that could be a barrier to her treatment.
Yeah, and a barrier to my chart review of her was that I saw her with Dr. Muhammad Umar, and I was only with him when I was on the day teams, but I mostly worked cross cover on nights. So my preceptor was someone different for this case. So that was also another barrier, because I was like looking at her through my account, and I didn't want to like mock up her chart with my name all over it or anything. So I was being kind of cautious in regards to that. But yes, I know from Dr. Umar's standpoint, he was very good about connecting those dots, like as you had mentioned.
Talking about the meningiomas, you did mention that she'd have the chest, abdomen, pelvis looking for metastatic possibilities. Are meningiomas typically benign or malignant, and do they usually metastasize?
Yeah, so I actually got a lot of information about meningiomas from Dr. Sieve as well. I did reach out to her in regards to the pathology report, because I was like, what does this even mean? So she kind of also informed me, then reviewing what she had taught us in neuroanatomy, and then doing research. So meningiomas are not common tumors, but very common intracranial tumors. So they're not common overall in the essence of tumors, but for intracranial wise, they are, and they're typically benign. They're derived from a arachnoid membrane of the leptomeninges, and usually solitary and have a benign course. And this is where also the grading comes into play. So she had a WHO grade 1. So meningiomas are graded on grade 1, grade 2, grade 3. Grade 1 are like the low grade tumors. They're the most common and benign. They don't meet any criteria for higher grade lesions. And then based on their morphology, they're pretty, removing them surgically is pretty much the mainstay of treatment for them. And then as you go up grade 2, grade 3, those are more cancerous, anaplastic, atypical lesions. So as far as this patient goes, they wanted to do the PET scan. So the PET scan was recommended by neurosurgery to the ED team, and they had ordered it just to kind of get this workup started in the ED. And so they had just read the scans on this meningioma and hadn't even like seen the patient yet, and ordered the PET scans and stuff. So I think they just wanted to kind of rule out any acute like metastatic brain cancer kind of thing going on.
So the nice thing, you can actually be able to tell the patient, it's like,
yeah,
you're okay.
And she's 35 with no medical history, so she was an anxious, really nervous patient, but we kind of settled her down after we got everything, got the answers like that she wanted.
Yeah, kind of, that's surprising. You've got something growing in your brain. So with that, you mentioned that surgery is the mainstay of treatment. Are there other options if she had opted to not have surgery?
Yeah, so we can do kind of like a targeted chemotherapy thing, which is why I kind of also looked into the recurrence rates for my evidence-based medicine, because I was wondering, like, oh, they removed this surgically. Like, what if they had done kind of like adjunctive chemo before, kind of either like shrink it before or after if she needed that in any type of way. And with the type of meningioma she had, surgery is really the best option. And this is also where the pathology report comes into play with the immunohistochemical studies that were done and showing kind of what this tumor is made of, and the DNA methylation and kind of things like that, like the tumor markers. So you can target specific tumor markers, kind of how chemo and radiation is advancing, that you can target specific things in that tumor. So same thing with meningiomas, but as far as her meningioma goes, the WHO grade 1, the surgical resection is the lowest chance of has a really low chance of recurrence.
Great. Any other questions for Emily?
Emily, I actually have a question for you.
Yeah.
So I found your presentation really fascinating, especially because we're just about to start neurology and clin med. But I was curious as to why this patient was receiving famotidine every 6 hours for GI prophylaxis if she didn't have like a history of GERD or reflux.
Yeah, so as far as the famotidine goes, that was recommended specifically, like it said in the ED note, like neurosurgery in the inpatient, neurosurgery recommends famotidine for GI prophylaxis. And I was kind of like why? Like I was kind of wanting the same thing. So I think with like the high dose steroids that she's getting kind of for the cerebral edema, and then eventually going through neurosurgery and everything like that, and she did have occasional nausea, vomiting associated with this tumor. There's a lot of different factors that can go into why a patient can be nauseous. And I think that famotidine was kind of more of a very, very prophylactic measure so that they didn't have to kind of chase something if it got too far. I think they were just really prophylactically treating her if any GI upset or anything would have happened. And because she was getting pain medication, which can cause a whole slew of GI issues as well.
I also have a quick question too.
Yeah.
And I'm just genuinely curious. I'm not sure if this is even something you would have looked into, but is this like condition, is this something that would have like a genetic predisposition or just kind of like happens at random?
Yeah, so that's actually something I was super curious too, because this patient mentioned, oh, my mom or grandmother also had weird episodes of blurry vision at some point, and I was like, is this genetic? So then I really looked into, that was mostly what my differential is made up of, the causes of meningioma, because I could have easily done, oh, this is a differential for a headache. But when I saw the patient, all the scary headache things were mostly worked up on, and she's not having a migraine anymore. So, so I looked into like neurofibromatosis type 2 is a big genetic cause of meningiomas. Like over half of patients that have or are diagnosed with neurofibromatosis type 2 have a meningioma at some point in their lifetime, and with the most common occurrence being at a younger age, and then after they're kind of like middle age, the occurrence like kind of goes down a little bit, but then increases as they get older. And then same thing with the schwannomatosis. Those two conditions are genetic related, but those have a higher incidence of having meningiomas. This patient, I don't know if that was the cause or not. That's why I was kind of in my plan I would like to get genetic testing on this patient to kind of see if there's a correlation. But neurofibromatosis type 2, which has the highest occurrence of meningiomas in itself, is very rare.
Thanks.
Great job. Thank you, Emily.
Thank you.
So our last presenter is Caroline.
So hi, I'm Caroline. I recently just did my rotation at Bay State Wing ED. So I saw a 48-year-old man. He had no significant past medical history. He presented to the ER with a 3-day history of hemoptysis. He was COVID positive back in December, but he only had mild symptoms like a cough, a little mild fever, only lasted for a few days. And he's been feeling well otherwise since. So on presentation, he denied any upper respiratory symptoms such as fever or shortness of breath. And on exam, he was hemodynamically stable, not in any respiratory distress, and he wasn't ill appearing at all. So essentially, PE was pretty high on our differential at the time because we did have a concern for COVID coagulopathy. So we found his dimer was elevated on lab work. So we got a CT angio. which did show a possible infarct in the right lower lobe, also a right-sided saddle embolus, and a suspected right atrial thrombus. So we ended up admitting him to Baystate after talking to cardiology, as they were pretty concerned for that right atrial thrombus. And so we started him on heparin, admitted him, and he ended up getting a repeat CTA and a repeat echo, which showed a decrease in the size of the embolus, and then no more thrombus in the right atrium. He was sent home on oral anticoagulation, apixaban, and then he was sent for follow-up in 2 to 3 weeks at hematology for this possible unprovoked PE.
Okay, I have a question from Professor Sprague. So can you clarify your treatment of apixaban? You stated 20 milligrams daily times 7 days, and then 10 milligrams times 3 months. Was it once a day or twice a day dosing? Can it be given just once a day? And then what is the half-life?
Sure. So we did not start him on apixaban. That was actually Baystate main campus's dosing for him after. So we started him on heparin, and then once he was admitted to Baystate and then he was discharged, he was started on apixaban. I'm not actually sure of the half-life. I can look that up, but I know that the dosing is 20 milligrams for the first week and then 10 milligrams for the next 3 months. So he was started on 3 months of apixaban. So that's normally the typical dose that you would give for an oral anticoagulant after a PE or a DVT. And then once we send him to hematology and he gets a workup for that unprovoked PE, they would consider either continuing him on oral anticoagulation for a more extended period of time or stop it after the 3 months.
So I'll jump in and fix that for you. So apixaban has to be given twice a day. So this is one of those things where you have to be really careful with the instructions you give your patient. Mm-hmm. The half-life is between 5 and 6 hours, but really it stays kind of for 12, which is why it's a twice-day dosing. So if this person was only taking it once a day, they're not managed therapeutically. There's going to be a trough with that. Mm-hmm. So
it probably, yeah, sure.
It comes in a 5 and 2.5 milligram dosing.
Right. Okay. It probably was twice a day dosing. I was just reading the note from the Baystate campus, and I think they probably just wrote, 20 milligrams. I'm not sure if I saw that patient education or
how confusing that can be and how that can lead to a medical error.
Yes, I can see how it can be confusing.
Okay, and then there were 2 questions that were sort of the same, so I'm going to just put them together. Mm-hmm. There was the question about why was there a D-dimer ordered initially if you sort of knew that they were going to order a CTA, which sort of goes into, what was this patient's Wells PERC criteria and how would we use that diagnostically?
Sure. So really the only initial symptom that this patient had on presentation was mild hemoptysis for 3 days. So, that is his really only PERC positive score that he was given. So he was PERC positive, which means you can't rule out a PE or DVT. But his Wells criteria score was either low to moderate. So he did kind of have a clinical sign of a DVT. He wasn't initially complaining of calf pain or lower extremity swelling. And hemoptysis was really the only other thing on the Wells criteria too. So he had a moderate risk for Wells criteria, and then he was PERC positive. So we did get a D-dimer knowing that we probably were going to get a CT angio anyway, but probably just because we just wanted to evaluate the D-dimer because he had that moderate risk for Wells criteria.
So then I think it makes me think, if the D-dimer was negative, mm-hmm. would you have gotten a CTA?
We probably would have anyway, because we did kind of have high suspicion because of the recent COVID infection, and he's a pretty healthy guy otherwise, and it was pretty high in our differential. So I can see why D-dimer is pretty, tricky, thinking, do you get the D-dimer or you don't? So I did have that discussion with my preceptor to get it or to not. And she just decided with me that, we should get it anyway, just because we were going to get the CT. And I guess it was just kind of a tricky decision to whether or not to get the dimer or not.
Okay.
We dimers can be tricky lab tests, and even now at Hartford, if you're ordering a CTA, it prompts you to say, like, you didn't order a dimer, do you want to? And the only way to really click out of that and to not have ordered the dimer is when you have high test probability. So if you go into this thinking, my most likely diagnosis right now is PE, there are significant risk factors, you really don't have to order the D dimer, because like Dr. Mijan is saying, like, even if it was negative, you're still going to order, it's still going to be your most likely diagnosis, and you're still going to order a CTA. So dimers can get really tricky in terms of what they actually tell you or don't tell you.
Right.
Okay, was there any other questions for Carolyn? All right. Well, that is it then. Great job, everyone. Thank you for answering our questions today. Really great presentations. You guys have come so far since June, haven't you? Can you reflect on that too a little bit to see that you guys are doing so great? Your presentations are awesome. All right, so that is it. Everybody can go off to your labs, and clinical students that have summative exam testing at 2 o'clock, get ready and have a great weekend. Bye.